It's really a particular delight to be here because all of you are the ringers of network interoperability and health information exchange. So really want to sort of engage all of you in where we are and the magic of the moment that we're in right now. First off, I do want to give a tremendous amount of credit and kudos to Alex Muggy, one of the delights of taking this job a year and a half, almost 2 years ago. It's gone very fast. Is the opportunity to be able to work with folks like Alex, the federal career folks who are so committed and so incredibly knowledgeable, as you saw, and really entrepreneurial in the ways they think about, helping to have the regulatory impetus to be able to help the market innovate and to keep moving forward. So that's just been a delightful part of the job, is working with Alex and the team at CMS, as well as the other federal partners I'll talk about in a second. As we think about interoperability, as kind of reflect on, I've been in this now for 21 years, something like that. Started in health IT in Indianapolis, working with Mark Overhage and Clem McDonald and the folks out with the Reagan Street Institute to help to found and launch the Indiana Health Information Exchange. And I think back on what we were doing back then and the things that we would have loved to have been able to have. Back then, you may recall this, like 2001, 2002. So the HIPAA privacy and security rules were just being released and modified in those early days as well. So that was just very fresh to the market, very fresh in all of our understandings. No one had EHRs, of course, right? We were trying to build phone networks and no one had phones. So that was a little part of the challenge. There was no high capacity, high speed, high bandwidth commodity internet. So Clem and Mark were literally laying down T1, T3 lines all across the city to connect up these hospitals to be able to get the kind of data that they were able to get into the Reagan Street system. And we didn't really have anything to point to above us. As we were thinking about interoperability and the things we were building, it's like, well, it'd be great to be able to point to something else, to be able to say, what is going to connect us up to everything else? Here we are just trying to figure stuff out, in our market here, but it would be really helpful to have a North Star, to be able to know where is all this stuff headed, and that we don't have to figure it all out by ourselves, that there are going to be others, and that interoperability might extend beyond kind of geography to other sorts of affiliations. Of course, back at the time, as all of you, or many or most of you may recall, we were thinking very much at the time of interoperability and nationwide interoperability being this kind of geographically connecting up the geographic kind of health information exchanges. So we started in in Indianapolis and Rhode Island, a number of places, and then Meaningful Use program came along, and the HIE program, and every state got dollars to try to build a health information exchange. Did a lot of work in New York, working with New York and the regions there. All of it was sort of this geographic orientation. And as we know, that all worked magically, right? It worked perfectly. Every state has an exchange, and we're able to connect them all up. No, and I think that was a very great experiment in thinking about how this might work. And there are lots of things that do work at that state level, as we know. Think about the health insurance exchanges, for example, where that does follow the way that insurance is regulated. But as we've seen, interoperability has sort of unfolded in ways that are very different. The shape of interoperability, the trajectory of it, the dynamics of it are really, really different than what we thought it was going to be, certainly back then. And even, as we started to enter the Meaningful Use program, and, we get a lot of, sort of criticism from various places that, that the Meaningful Use program should have, sort of front-loaded interoperability, that we should have been doing that from the start as we thought about EHR adoption. I would submit that would have been one of the biggest mistakes we could have made with that program. Now, I wasn't in the federal government at the time, but when you think about how complicated interoperability is and how different it is now than when we were starting on that, on that Meaningful Use program, starting to make those investments in EHR systems back in 2010, 2011, 2012. I think that if we had said we're going to have interoperability from the get-go, first off, we would have had rebellion. No one would, there would have been incredible challenges with adoption. But we also would have built, the healthcare versions of CompuServe and AOL. And we'd be fighting to break our way out of, why did you idiots build this old-style architecture and lock us into these old computer networks? And why didn't you, preserve the option to make decisions down the road to allow innovation to unfold and only make the decisions when you need to make the decisions? I would argue that's where we are today. So we've got, tremendous opportunity now The dust has settled on a large part of EHR implementation, which is fantastic. So we've got phones all over the place now, and connecting them up, we've had a tremendous amount of progress in the work that is done by all of you. Really, this is about everyone in this room contributing to the local, state HIEs, the nationwide interoperability networks that we have, which have been fantastic in doing provider-to-provider exchange for treatment purposes. Right? We've got tremendous amount of progress there, and I think it's really a testament to all the hard work that all of you have done. And I would argue the industry does not get the credit that it deserves for the tremendous progress that's been made there. Carequality alone, I think, does something like 50 million transactions a day. That compares very favorably to the Swift Banking Network, it turns out. Swift Global Banking Network does like 40 million a day. So, and that's just Carequality alone, and that's not what happens within individual networks. So, tremendous amount of progress and tremendous growth. One of the things when I came in to this job, which was, as I said, almost 2 years ago, in 2021, was that, TEFCA, when I came in, seemed like it was, had slowed to the point of almost being at a standstill. There was still, work going on. I was outside in the market. I didn't really see sort of where the progress was. It seemed like there were a number of, things that had stalled it. And so one, hard look and hard consideration that we have is, what should we do with TEFCA? Should we move forward, or should we put it on, sort of a glide path, euthanasia, as it were? And we decided that there was a lot there. There's a tremendous amount of value there. And what are those things that seem like gaps? One of the things, first off, is that that there are, as I said, there's tremendous amount that has been done by the private sector, and I was proud to have been very much a part of that with working with Carequality and the Sequoia Project and eHealth Exchange and the Commonwealth Health Alliance, all of those organizations that help contribute to where we are today. But I also observed the slowdown in the progress being on that side of the federal wall. The provider-to-provider exchange for treatment purposes got a lot done, and a tremendous amount got done. But then on the other use cases, it was really hard to make progress. What are those other use cases? Well, something like 30% of hospitals are not connected to any of the nationwide interoperability networks. They're probably rural hospitals, critical access hospitals, less well-resourced hospitals. They don't have the technical capability. They have tremendous market confusion. They don't know exactly how to sort their way through all of this, so they just don't. Right? Something like 30%. So we've got tremendous amount of progress, and that seems to be, sort of plateaued right now. It doesn't seem like we're making a lot of progress in penetrating, that part of the care continuum, which is a really important part of the care continuum. Payers have been effectively locked out. Now, I know there's some progress here, but there's been progress just around the corner for a number of years now. And we still have a hard time doing it. And that's a part of the market complexity, right? There's a lot of competitive stuff in the market. The payment models are really complicated. People feel, worried and concerned about, their data being made available to other parties and used for other purposes and all of that. But that, that was a glaring gap, I would argue, that didn't seem like, and still doesn't seem like it could be rapidly and effectively filled by the private sector. Public health, right? Enormous gap. Public health effectively closed out of the interoperability networks, not for the fault of the private sector in trying to do that, but because public health is really complex, would be the judicious word to use, right? The regulatory the regulatory landscape in public health is something that the government created and that the government needs to be involved to help resolve as we think about interoperability. Individual access. As we know, individuals are allowed technically to participate in the nationwide networks, but and in state and local HIEs as well, and some of them, as we know, that really just hasn't had a whole lot of traction as well. So, and finally, as we're looking at TEFCA, was silent on FHIR, right? The early version of TEFCA was silent on FHIR. And had a number of other things that I think, as we looked at it, that was just not, it was not going to scale. So we did a reset. So we said there's a tremendous amount of value here that at its core is about taking interoperability to the next level, building on the tremendous work that all of you have done, and to say, in order for us to get to the next level, we really need to have a public-private kind of partnership approach here to be able to get it to the next level, to be able to have that kind of nationwide governance and a forum for us to be able to have a nationwide conversation about where do we want interoperability to head, and how do we resolve these issues, and how do we address these gaps, and how can the federal government presence, either through just helping to facilitate things and helping to move things along, as somewhat of a neutral arbiter in certain cases to be able to help things move along, where we can help on the regulatory front to help bring certain parties to the table to be able to help to resolve some of those regulatory issues, and where can we use our regulatory and purchasing power to help support what all of you are trying to do in the market as well. I mean, all of those things I think spoke to, at least to me in the ONC team as we looked at it, as if not the primary reason for us to kind of move forward with the TEFCA model, to be able to have that public-private kind of collaboration to get us to that next level and to be able to help the market pull through and overcome some of those barriers. So what do I mean by that? What does that mean as we move forward? We're doing a ton of work to try to help, and I see Zoe Barber there, who's been doing a lot of work with the Payment and Healthcare Operations Group to start to think about what are the ways that that we can bring payers and providers together. In a lot of those conversations building up to this, I've been speaking a lot about, gee, it would be great if providers shared clinical information with payers, which we know has always been a part of the conversation, but if payers, instead of offering US CDI or clinical data back, could offer claims data back. And boy, it would be really great if payers thought about that. And of course, I couldn't say what finally came out in rule, which is in the draft rule is going to say that you really need to do that. Actually would be required to do that if it gets finalized by that. So I think that helps to set up, for example, sort of the model where both parties feel like there's something valuable there that we've been able to break through from where the private sector had difficulty breaking through, to say that that we can move forward to get something that providers and payers both feel like they're getting something out of TEFCA. Trying to figure out how we can orchestrate our federal levers to get at that 30%. And that's just the hospitals, right? On the ambulatory side, it's probably bigger. And you think about whole parts of the care continuum, behavioral health, LTPAC, all those parts of the care continuum that we've got, a lot of engagement now across the federal agencies to say, how do we start to orchestrate that? How do we start to think about all the various levers we have to be able to, sort of address that gap that, again, only the federal government, I think, can play that role in working with state governments to be able to try to, sort of fill that gap and help us move forward. Public health. We've got, a lot of engagement and ongoing, very active work with the CDC and with various STILT partners, state, territorial, local, tribal public health agency partners, to start to think about what would a public health network look like on TEFCA. And no firm decisions have been made, but we've got a lot of conversation going on. If you look at the Data Modernization Initiative, that's the over $1 billion effort that the CDC has to modernize our public health infrastructure. TEFCA is at the core of it. TEFCA is a fundamental part of the way we're thinking about how do we get the scalability that we want to be able to have for STILT CDC exchange, going back and forth, STILT to STILT exchange, right? Right now, jurisdictions have a very difficult time communicating with each other, and to the extent that they do, it's all one-off, all negotiated one-off kinds of exchanges from a technical perspective, from a legal DUA perspective. Why don't we just have a network where they can interoperate with each other so that Texas and Oklahoma and Arkansas can share information, in rapid cycle and in the ways using commodity pipes, using commodity, data exchange models that providers benefit from now in interoperability exchanges. And importantly, to be able to ease the reporting of data to public health systems so that all of you who work in multiple states, I know there are a number of you here who work in multiple states, you're not having to say, oh, geez, I need 64 different DUAs, 64 different versions of that same darn HL7 V2 interface because every state has got its own flavor. How do we say, just make that a network function, just scale that at the network level and allow that to happen. And that's the way that we get sort of the scalability in the public health side. And importantly, a key finding, I think, from the pandemic as it relates to public health is that it's not integrated with the healthcare delivery system. That we don't get the information from the healthcare delivery system in rapid fashion and reliable and accurate fashion. And equally important, we don't get any information out to the healthcare delivery system, which makes it a benefit to providers when they're thinking about, sending information to public health. Gee, it would be great if I got some information back and if it was valuable to me. On individual access, we're hoping to accomplish some work to be able to break through some of the regulatory hurdles and some of the things that have been blockers for individual access to be able to scale. I think that, as we think about IHE-based exchange and increasingly FHIR-based exchange, we're hoping that there are some pathways there that help us, scale that ability for individuals to be able to directly be able to get their information. And you heard everything that Alex was talking about, the ability to get your claims data and your clinical data. And as we think about prior auth and other kinds of things, you can imagine the opportunities to just be able to say, I can interact, in a variety of ways using that kind of network functionality and scalability if we're able to get that kind of consolidation as well. So there's a lot of work going on along all of those dimensions. Then finally, FHIR. As we think about the, TEFCA and looking at, things like the FAST initiative, as we were, observing very closely. Hans and I co-chaired the FHIR work group of Carequality as we were starting to think about how are we going to, sort of have FHIR enable exchange in Carequality. We, sort of made the observation that TEFCA can't be silent on FHIR. TEFCA actually has to be something that helps to enable and scale FHIR. And as we work closely with CMS, with our CMS partners, and thinking about the market, and working with the Smart on FHIR folks and the Argonaut Project folks and Da Vinci, and again sponsoring and participating in the FAST initiative and seeing what the folks in the FAST initiative were surfacing as real issues, which was the scalability of FHIR APIs. As much as we want to push on FHIR APIs, and CMS has a whole portfolio of FHIR APIs, which is great, right? It's fantastic. But the issue of scalability was going to present a real barrier, I would argue, to the ability to have the kind of sort of FHIR APIs and the ubiquitous access to those in a way that allows the interactivity, the ability for systems to dynamically interact with each other that we want to be able to sort of benefit from and to leverage FHIR for. So the opportunity to be able to say there is network infrastructure that we can provide through TEFCA that allows those basic functions to allow FHIR APIs to scale, right? That allows things like record location, endpoint directory discovery, endpoint discovery, security, scalability of certificates, so I'm not having to negotiate this every single time, and scalability of rules of the road, right? All of those things that network infrastructure offers, but allows APIs to still communicate with each other. Right? So this isn't about, so this is about saying that's where FHIR lives right now. Now, maybe in a future world, there's a mediated, sort of FHIR transaction through things like QHINs or networks, and that, that's totally fine. But we want to be able to meet FHIR and the FHIR community where it is today, which is living in the wild with FHIR APIs connecting with each other. And if that ends up becoming the, the long-term model, that's fine. But it's about saying, how do we use network infrastructure to support that scalability? And there are a number of, of key stakeholders, like payers, for example, who, many of whom just want to jump to that. Right? That's what they want, because that's where they've been building since they were, sort of effectively closed out of the current kind of model. Thank you very much. A lot of them are saying, we don't see a need to do that. We really want to move to FHIR APIs to be able to do that. So we think that's a real benefit that TEFCA can offer to allow that kind of opportunity for, for organizations to be able to participate in that way as well. So we're really, really excited. And all of this was, we, as Alex had said, came in January of 2021, did a hard evaluation. Oh, I actually had a conflict of interest because I was on the board of the Sequoia project that prevented me from doing anything with TEFCA for like 5 months. So I'm sitting in the office like, so what's going on with this TEFCA thing? Can anyone tell me? It's like, nope, we can't tell you a thing, like literally not a thing. So finally got the COI cleared, and you can imagine the next day it was like, send me everything. I want to see everything. And anyway, and then we did, spend a lot of time, and it's real credit to the ONC team and to the RCE team, and Marianne and Alan and Dave and Zoe and, the entire team have, just done a tremendous amount of work to get us to where we are today, which is, in January of this year, as Alex said, publicly released the common agreement and the QTF, and that had a lot of revision and changes from the previous version. So that was a ton of hard work to get us to that point that we could get through those in a way that that was something that we thought was meaningful and was still something that was going to be something that the industry would have a glide path to, but opens up the opportunity for innovation and for the closing of the gaps that that exist today. We opened up the applications in September. And as Alex said, we had 10 organizations, I think, have submitted letters of intent of their intent to apply to be QHINs. We are anticipating having an event. We are going to have an event. We're going to have an event, an HHS-sponsored event in early 2023 to announce the first QHINs that have gotten through that approval process, which is the process where they have submitted their applications. The Sequoia Project and the RCE have looked through their applications, and they have met that first hurdle of having their applications approved, and they are signing the common agreement. So at that point, they've said their applications are approved from an eligibility perspective, and they've agreed to the legal terms and conditions of the common agreement, and that starts them on the path of, within 12 months, going through the testing, onboarding to be fully designated as QHINs. So that's why 2023, we think, is going to be the go-live for TEFCA, which we're really excited about. I mean, that is a lot of stuff happening in a very short period of time. The fire roadmap proceeds in parallel. So we're organizing fire pilots with an eye toward having production or real pilots in 2023, and production of fire-based exchange, production fire exchange in 2024. Which is the current roadmap as well, to go in parallel with that and follow fast on the heels of being able to just establish the governance model, let's get some QHINs up and running, and then let's work in parallel with those organizations that want to really do fire-based exchange and use this to scale their APIs to allow them to do the hard work and the pilots for us to then be able to bring those live as well. Last thing I'll just mention is that we've got a lot of work that I underappreciated before joining ONC, is the opportunity to do work coordinating behind the federal wall with our federal partners. So we're doing a ton of work with CMS. Alex, told you, I know, Stephen, you asked her to give you firm plans on what CMS is going to do, which of course she can't answer. But I think you saw that they're leaning, heavily into the hope that the TEFCA can offer a whole bunch of stuff, and we're thinking about a lot of what are all the things that that CMS can do, both from the payment side to incent providers, as well as the kinds of things that they do as an organization. We're doing the same thing with the CDC, as I described, thinking about the public health network, and we've had a lot of conversations about how that would help to support the data modernization initiative and get us to a completely different way of thinking about public health interoperability. We have a lot of conversations going on with NIH and OSTP, the Office of Science Technology Policy, who are starting to think about what are the research cases here. Now, that's not a required exchange purpose, but one of the reasons we didn't make it a required exchange purpose is that it's complicated. And so that means you start the work now, right? The fact that it's complicated means you don't defer, you start the work now. And there is a lot of appetite and interest in starting to think about everything from clinical trials and distributed clinical trials to basic research kind of capabilities to cancer navigation. And why don't we think about cancer navigation, providing tools for cancer navigation as a part of research, identification of cancer, getting them into trials. That kind of sort of capability. So there's a lot of ongoing conversation there where we're working really hard with our federal agency partners for them all to just think about the minute you think about getting information, you should be thinking about TEFCA. That should be the way that you think about it. And then we'll think about, sort of if that doesn't meet the need, then there are other ways of being able to do that. The Secretary Becerra, over the summer, signed a policy that requires that within HHS, all HHS agencies and all of their funding mechanisms and all of their policies are required to put in as standard contract requirements the use of ONC standards related to data, related to everything that's in EHR certification, for example, so data, fire APIs, and increasingly we're motivating and pushing that, that TEFCA be a part of that. It's not a requirement today. TEFCA has to become real first. That would be, so the first thing you want to do before requiring it, but just to give you a sense of, what we're trying to do to say the federal government should be using all of our purchasing power and our regulatory power to do the things that we want industry to do. That we should be, exemplar citizens for all of you, and to help motivate all of, everything you're trying to do, and really try to do everything we can to run interference or set picks or whatever your, favorite sports analogy is, so that all of you can rush through and be able to do the kind of innovation that you want to be able to do, and not have, technology be the barrier, and not have the federal government be the barrier, but hopefully have the federal government be an enabler of, of what you're trying to do. So I know I said a lot. I hope that's really helpful, and I hope it's motivating. That's that's the last thing that I want to be able to say. When I took this job, I thought about, well, how long am I going to be here? And if I'm going to take this job, I am just going to go big or go home. And I'm not going home anytime soon, so this isn't, I am not going home anytime soon. And, so we're leaning as heavily as we can into all of this. And, TEFCA is just one piece of it. Fire APIs are another piece, and we're trying to make sure that these things complement each other as we think about TEFCA, the requirement for FHIR APIs to be made available by certified EHR technology vendors by the end of this year, information blocking, everything we're doing there. We're trying to do everything we can behind the scenes to have those things all complement each other as they all sort of start to come to the market and start to come to being regulatory requirements all around the same time. So last thing I would encourage all of you to do is take seriously Alex's request to respond to those RFIs. Those are really important. The TEFCA RFIs as well as the other RFIs. One of the things that I've noticed being a federal employee now that I just sort of kind of knew but didn't fully appreciate, every single comment is read. Every single comment. If there are 10,000 comments, 10,000 comments are going to get read, and every one of them reconciled in some way. Do we take this? Do we not take it? Do we, modify it? Why are we not taking it? Every single one. So, she was very serious when she said, CMS and ONC and, CDC, NIH, all of us have a roadmap that we're putting together, but it is shaped by everything that you want us to do. I mean, because we're not, we're trying to say, how does regulation support what you want to do? Not, how does it force you to, sort of do things that are complete unnatural acts. Obviously, sometimes there's some nudging of doing things that maybe you're reluctant to do, but overall, it's about saying, how can it be an enabler? So I encourage all of you to look really hard at those RFIs, and please submit your comments and your feedback to those, because those are enormously helpful. So thank you very much. Really delighted to be here. Thank you for the opportunity, Alan and the Sequoia team, and look forward to the rest of the conference.